Good evening and welcome. Glad to have you on this special night for Alma College. It's been a terrific day as we've brought pre-med students together with prospective pre-med students and pre-allied health to think about where the future of medicine will go. It is an exciting time for us at Alma College as we contemplate what pre-allied health will be in the years ahead. This has been an area for us of great strength through the many generations. And we're proud of all those we've sent out to the world to become doctors practicing in the world, across the globe, literally. It's an exciting time for us as we redefine this program. Well, I'm very pleased that we were able to welcome Dr. Leonard Calabrese to Alma College. I will tell you that I've known him for some years, and it's an odd thing. He is a physician, a DO, who has earned a global reputation. He has published literally hundreds of articles across the world in many, many publications, and yet you sit down with him the first time and he says, "Hey, call me Len." Well, this is Dr. Calabrese's approach. He is a man for the liberal arts. He is a graduate of John Carroll University, a very similar school to Alma College, and he is an individual who in his medical career has taken a wide range in his approach and in his many interests. He has a wide-ranging intellect. As someone who, to sit down with him, you can talk about anything from ballet to music to wine to any aspect of contemporary medicine. It's a great privilege for us to have him here tonight. It is as well a privilege for us to honor him with an honorary degree, and we will begin with that. And for that citation, I'd introduce our provost, Kathleen Doherty.
Good evening. Dr. Calabrese, in recognition of your exemplary career spanning nearly 40 years as a physician in the field of osteopathic medicine at the world-renowned Cleveland Clinic, and in tribute to your pioneering work in clinical immunology and rheumatology, treating some of the most complicated cases in the world, and authoring more than 350 published peer-reviewed articles, book chapters, and reviews, and in admiration of your work and expertise in HIV, testifying before Congress, consulting businesses on the bioethical issues surrounding the disease, and emphasizing a humanistic approach to patient care that has earned the trust of thousands of patients and colleagues throughout the years. And in acknowledgement of your outstanding character, membership in numerous societies, and the many deserving honors you have received, including the Bruce Hubbard Stewart Award for Humanitarianism, the Leonard Tao Humanitarianism in Medicine Award from the Arnold P. Goldman MD Foundation, and recognition as the 2014 Physician of the Year by the American Osteopathic Foundation, and in grateful appreciation of your commitment to teaching, continuing education, and your willingness to share your knowledge with prospective health professionals. Now, therefore, I proudly present you Dr. Leonard H. Calabrese for conferral of the honorary degree of Doctor of Letters.
Thus presented our newest graduate. We'll give a talk this evening, but first, Dr. Karen Ball has a more formal introduction. Dr. Ball.
Good evening. It is a distinct honor to be able to introduce tonight's speaker, Dr. Leonard Calabrese, head of the Cleveland Clinic section of clinical immunology. Dr. Calabrese completed his undergraduate work at John Carroll University, and as Dr. Abernathy just said, it's an institution that is very much like Alma College. His medical degree was earned at Kansas City University of Medicine and Biomedicine, which was one of the original 5 osteopathic medical schools in the country. He followed this with residency training in internal medicine and a fellowship in rheumatology at the Cleveland Clinic, where he has since served in his position in the Department of Rheumatic and Immunological Diseases since 1980. In addition to the many awards he's received as noted in the honorary degree citation, Dr. Calabrese also holds the R.J. Fassenmeyer Chair of Clinical Immunology. And in 2008, he was subsequently named the Theodore F. Klassen Chair in Osteopathic Research and Education, making him the first at the Cleveland Clinic to hold 2 named chair positions. Dr. Calabrese has traveled extensively presenting on his work related to immunology, rheumatology, and we're delighted to have him with us to talk this evening about a different aspect of his work, that being empathy in healthcare. So please join me in welcoming Dr. Calabrese.
Well, I'm extraordinarily honored to be here. And getting this degree is really cool because I didn't even have to take an exam. So this is, wish I would have figured that out earlier. I'm going to segue from what I usually talk about, which is molecules and gene transcription and epigenetics, talk about something that I think is of interest to all of us. Whether you're a pre-med student contemplating a career in health sciences, whether you're a faculty person who exists as a mentor and a teacher, but also a patient, or a healthcare provider. I will say at first, there's 2 goals of everyone when they become sick. You want a fine physician who is going to diagnose you and treat you with extraordinary expertise, and you want someone that actually understands what you're going through. Sometimes you want a little bit more of one, and sometimes you want a little bit more of the other. Sometimes that's all that there is. So I'm going to start by giving you a hypothesis. The hypothesis is that empathy, which I will define, and mindfulness, something that you have some, certainly awareness, you probably have a definition in your head. Both of these attributes lead to better care and better caring of people who need to be tended to when they're sick. So that's the hypothesis. I'm gonna do this in 3 stanzas. I'm gonna work through this. I'm going to talk to you a little bit about what empathy is and talk about some definitions that we have to be on the same page for. And then I'm going to show you some evidence of empathy science. I'm going to turn and talk about mindfulness. And I'm hoping to intrigue you at the minimum that this may be something that you find of interest and may want to explore further, either personally or academically. So I get the privilege. So we have a medical school, it's a new medical school, it's only been around for barely 15 years. So ranks it as one of the newest medical schools in the country. And I was telling people at dinner, it's kind of an interesting school, you know, that we don't have lectures, we don't have tests, we don't have rank. It's a kind of a highly interactive school. But I get to give the first day, the first lecture of the first day. That's a very sacred time. Everybody's kind of anxious, a little wigged out. You know, we've got 5 years to go. And I showed this slide. And I said, medicine is based on 2 pillars. Technophilia, which is your love of technology. And anybody who goes into medicine or anything in the healthcare, science is crazy. To learn the science of medicine is very formidable. We always say it's like drinking water from a fire hydrant. You're just taking it in, knowing that within months there'll be new information information to replace the old information. So that's everything. It's anatomy, physiology, diagnosis, chemistry, radiology, genetic science. But there's another pillar that we don't talk about as much, yet is equally important in terms of caring for people. We call that philanthropia, and that has to do with our love of man. And this is our humanistic approach to medicine. You know, you want someone who not only is fine technically, but you want someone who can actually understand where you're coming from, where your suffering is coming from. So, with these two things in mind, and I will tell you this, just to back up here, traditionally in medical school, this has been a tough sell. Everybody, you know, over here is where you take your boards. Over here is where you live your life. So this is also difficult because, you know, there are not scales for this by and large. It's hard to get your hands on. It's hard to get your head around. So there's a traditional aspect of that. So the definitions I want to work for are empathy. So this topic. And so empathy, you have something in your own mind. You think it's, you know, I can understand what somebody's going through. That's where usually it leaves off. It really plays a critical part in this interpersonal choreography between healthcare provider and patient. It's kind of ineffable. It's very hard to get your hands on a precise definition. The question is, can you teach it? One of the first questions I had when I went into this field in the past decade was that, can you teach empathy? Can you make people not lose their empathy? Or is it just predestined to have this? Or can you buffer that? So in healthcare, I'll give you the rapid summary. It's correlated with a lot of very positive things about healthcare, and I'll go into that in a minute. The term empathy comes from the Greek empatheia, which really is a concept of feeling, actually deeper than feeling, a very close feeling. So this was not where medicine has gravitated to in its definition. And it wasn't until the late 19th century that the Germans kind of riffed on this, and something that they referred to as Einfühlung, which they said was a kind of an empathic feeling where you could take a piece of art, a great piece of art, and actually identify with, you know, emotionally. Like, okay, I go for that. But it wasn't until Theodor Lipps, a philosopher at the turn of the 20th century, he actually kind of pushed this ahead and said, it's really about a feeling one's way into the experience of another. And that's really closer to what we talk about when you say, oh, you're really empathic. I can see where you're coming from. This is the definition I will use for the rest of this conversation. This is a book, if you're really interested in empathy in medicine, empathy in patient care. This is the second edition of Empathy in Patient Care by Dr. Hojat. Hojat is one of the leading scholars in empathy in medicine. He works at the Sidney Kimmel School of Medicine at Thomas Jefferson University. And he says empathy is predominantly a cognitive attribute, which involves understanding the experiences, concerns, and perspectives of another. So I've said cognitive, all right? So it's really an understanding. But he also says it's combined, once you understand this, with a capacity to communicate this understanding back to the person you're with. I mean, what does it do? Good does it do? It's like, I'm empathetic to you if I just sit here and say, well, I get it in my head, but I don't let you feel that I know that. So the empathy is a bi-directional thing. And the bonus of empathy, the accelerating factor of empathy, is that in our definition, it comes with an implicit intention to help. All right? And if you're going into healthcare, this is what it's all about. Understanding what people are going through, letting them know that you care, and actually wanting to do something about it. And some people would give this. So what's sympathy? Is empathy sympathy? Now, sympathy, in our working definition, we look at sympathy as not being cognitive, but an emotional quality. It's feeling for someone, but feeling in an emotional context. I love this graph, which is empathy is primarily cognitive, sympathy is primarily emotional, but in our empathic feelings, yes, sooner or later, we have that same type of feeling, but too much sympathy will burn you out. You just feel like, I can't go on, I feel too bad for people. Empathy has enduring power because it does not drain our emotional batteries. Next term I want to talk about is healing. In medicine today, you don't hear much about healing. Think about physicians as being the curer of diseases. That's what we want to do. We want to cure disease. I ask this to medical students. What do doctors do? We diagnose and we try to cure things. Healing is somewhat different. Healing has different dimensions. And I like this one. It says, healing is making people whole again in terms of their body, mind, and spirit. So what does that actually mean? What's the difference? So someone who's in an automobile accident comes into the emergency room and they have blunt trauma to the chest and they develop something called a tension pneumothorax. So they rupture the inner surface of the lung, the air goes out into their chest, it starts constricting their lungs, and you can't breathe at all. Your chest is going to explode. And you don't need to be healed, you need to be cured. You need somebody to stick a trocar, make a hole in your chest wall, let that air out. And the person breathes and they're fine. That's curing. Healing is somewhat different. There's a question, can we cure without healing? So that person who's in this profound car accident, who came into the emergency room with a tension pneumothorax, who was in the car with two other people, maybe one died, maybe one was head injured, something like that. Well, we've cured the tension pneumothorax, but they're a mess. And they leave the hospital and they have post-traumatic stress disorder from this thing. They're afraid to go in a car. They're now depressed and anxious. Well, we've cured the disease, but we haven't healed them. Healing is different. The opposite of this is that, sometimes, cancer's a terrible disease, and even though we're making incredible gains on this disease with immunotherapy, you see commercials for all these checkpoint inhibitors on TV, many times there is no more therapy, and there comes a point in time that therapy is futile and withdrawn. And you have two ways to go. Patients go into hospice, they die, they're either at one with their universe or they are not. There are people who reach the end of their lives and spend these last days, weeks, or months, and they're physically okay. They're waiting for something terrible to happen, but their lives are torn apart. There's no joy. They have a hard time feeling the love of those around them. There are other people who get it and say, no, Doc, I don't want any more of this therapy. I want to go and, have some kicking times with the people that I love. And however long it lasts, it lasts. Those people are healed. They're not cured. And the other is not cured nor healed. So I believe you can heal without curing. I think you can cure without healing. These are very important concepts. I'll show you some evidence in part 2. These are not new concepts. Maimonides great Rambam of 1,000 years ago. I mean, these quotes, I mean, if I was brilliant enough to say this today, may I never see a patient as anything but a fellow creature in pain. May I never consider him merely a vessel of the disease. How good is that? I mean, it's talking about someone, they're not just the patient in Ward 9 with pneumonia. It's, you know, Mr. Jones, who's the father of Cassie and Alex, and the wife, the husband of Marie. You know, this is a person who has a textured life. You don't know who this is, most of you. This is the great Sir William Osler, the greatest physician of the modern era. He actually, if you headed towards medicine, he's the person that brought teaching to the bedside. He was an internist, the first great internist at Johns Hopkins. He's the most quotable guy in the history of modern medicine. He says many things, but this is one of his best. He says, the good physician treats the disease. The great physician treats the patient who has the disease. And that gets back to this notion. He's talking about healing as opposed to curing. Now, Osler worked at a time where there weren't too many cures coming down the way because we didn't have antibiotics, we had very few therapies. But it's a great quote. In a more modern era, in Boston, at Harvard, this physician is still very famous, Francis Peabody. And in Boston, still have the Peabody Society. He was a scientist, worked at Mass General, major teaching affiliate of Harvard. Yet he was known as a humanist. He has so many quotes. I love them all. He says, the treatment of a disease may be entirely impersonal. That's giving you your penicillin for whatever. But the care of the patient must be completely personal. And his most famous quote, and just to show that these are not new notions, is that the secret of patient care is to care for the patient. Now you think like, okay, this guy's telling me all this stuff, this is intuitively obvious, this is what everyone would want to have. There's a gap here. Why aren't we experiencing this in modern medicine to the degree that we all think that we should? And I'll show you some issues as we go along. So part 2 is about empathy research. All right, so I've told you what the definitions are. So how the heck do we measure this thing? I mean, I told you it's ineffable to begin with. That means that it's hard to understand. But there are ways of both qualitatively and quantitatively measuring this. And any of you who've taken psychology, you know there's so many different scales for so many different psychologic attributes. There are definitely validated scales for empathy, which I'll tell you a little bit about in a second. But at 30,000 feet, when you have empathy, it's been correlated with all these things that you would like to have. Low stress, improved quality of care, feel better about being on the job, better outcomes, and your patients like you better. What's wrong? I mean, who can argue with that? We know that there is an underlying science of empathy. And I don't know how many of you have heard of mirror neurons. This is one of the beginnings of the kind of the understanding of neurophysiology of empathy. So this is a functional MR, so you can see the brain, see these hot areas, these are hypermetabolic areas. So you could take a person, put them in a functional MR, the whole brain would be gray. And then you have a person come into the room, and you take their arm, and then the person in the functional MR is watching them, and you have them stick that arm with a needle. You're just watching this. You know what you do? You wince. Well, the pain, putting the needle in the arm of the subject that's being witnessed, that would cause pain to be registered in the brain. The mirror neurons are, as a person in the functional MR just watching this, lights up the same areas, not quite as intensely. But we have a natural, biologic thing, particularly for people that are similar to us. You know, similar demographics, similar race, look like us, talk like us, sound like us. We're very easy to be empathic to them. People that are disparate from us, it's more of a challenge. And I'll come to that a little bit later. But there's a neurophysiologic underpinning. I've already said that in the studies of Dr. Hojat and colleagues, all of these features have been correlated with high degrees of empathy, including less likely to be sued. Well, sure, you're going to sue a physician that does something bad or seemingly bad, who's a jerk. You know, we all make mistakes. Some of them are virtually impossible to avoid. And if you have a physician or a caregiver who's empathic with you, that you relate to, that knows, that has your best interest, and has been with you all the time, you're much more reluctant to try to make them suffer for something that may have not been of their fault. So it just makes sense, right? So this is the scale where most of the empathy research has been done. It's called the Jefferson Empathy Scale. It's been validated, it's reliable, has great internal consistency. It takes 5 minutes to do, it's 20 questions. You can go online and take it if you want to. It measures 3 domains. Perspective taking, can I understand what your perspective is? Compassionate care. What makes the Jefferson Empathy Scale different from all other empathy scales is that it was designed for people in healthcare. It's not just empathy in life, it's empathy in healthcare. And lastly, it gives us a domain of our ability to actually stand in the shoes of the person who we're caring for. Now, using the Jefferson Empathy Scale, there have been tons of studies done. So it's interesting. Empathy by Jefferson Empathy Scale doesn't correlate with how high you score on your boards, but it does correlate with your clinical competency on rotations. That's when a person grades you, like, oh, this person was great at surgery rotation. You know, they were, you know, I give them a global, you know, A+, because that includes not only being smart, but being there for the patient, etc. So it makes a lot of sense, right? Physician empathy and gender. Right? Who believes that men have more empathy than women? Raise your hand. Who believes that women have more empathy than men? Raise your hand. Okay, spot on. There's like a reference and a reference and a reference and a reference for that. So it's just the way it is. And a lot of work has been done from that. I don't really want to go into it, but you know, medical schools are now more women than men, and rightly so. Empathy and healing. So I've already talked about this notion of healing, getting people put back together in mind, body, and spirit. I'm going to give you some books during this talk. I already gave you Hojat's book. This book is a must-read. This is a must-read for anybody. I love this book. It's just published in the past few months. David Rakel is the chairman of Family and Community Medicine at the University of New Mexico. He hailed from the University of Wisconsin, which is a great research powerhouse. And he's done some very, very interesting work about the healing power of empathy and mindful listening. I'm going to tell you, I'm going to review a study with you right now. So this was David Rakel. Did it with my friend Bruce Barrett. It was called The Perception of Empathy in the Therapeutic Encounter, Effects on the Common Cold. So here's the study. So I took 700 patients who had the common cold. Now, at the University of Wisconsin, They're particularly adept at this because this is called the Wisconsin Respiratory Index. So they have validated questionnaires. Everybody knows what you have when you have a cold. So if you met these criteria, and you didn't have high fever, you didn't have this and that, you had a common cold, then you were randomized. So in studies, we're big on randomization. You don't just let people pick their treatments. We have to make them a random gambit that eliminates a lot of bias, right? You guys know this. So there were 3 tracks that you could be randomized to. One, just a common cold, you got a phone call. Somebody came up and said, okay, answer these questions. Yeah, you have a common cold, take some Tylenol, use these decongestants, drink a lot of fluids, chicken soup and stuff. And if you don't get a fever and this, keep me posted of how you're doing. And then they got these daily forms to fill out about their symptom intensity. How's your cold, stuffiness, aches, pains, fatigue, stuff like that. Group 1, phone call. Group 2, the basic visit. You went to see a healthcare provider. And that person listened to your lungs, took your history, did the same thing as the person on the phone, and gave you the same instructions, but was under orders by the design of the study not to overly engage, not to really smile, not to ask you, what kind of activities you missed, not to share anything with you, just gave you the basics. The third group gave the same medical advice, but it was an empathic visit. And at that visit, they were instructed to engage the patient. What's the worst part of this for you? Help me understand what you're going through. And let me try to help you with your, life's travails. Now, the 2 groups, the non-empathic and the empathic visit, those were randomized. And the people actually that were engaged in the study, the care providers, they had to be trained by professional actors. And when they went, the randomization process is that when you went to a visit, you said, okay, there's somebody in room 13, they met the criteria, they have the cold, they've agreed to be in the study. Then the provider would get an envelope, and you open it up, and you go, you're the empathic guy. And then the next one, you go open it up, and you're the non-empathic guy. So it was very rigorous. So let's just, and now we know that in 2 weeks, cold's going to be gone. They have a cold. So what did they see? So this is called a concert diagram, not important. So this is what you see. The top is, we call it subperfect care. This was the non-empathic care. The bottom was the perfect care. And the patient recognized this as an empathic visit. And each of these points are represented patients still reporting cold symptoms on that day. Now you can see that these curves are separate and it's statistically significant at 3 decimal points. And you say, okay, so now you can kind of, in your head, go like, oh, that's just a placebo effect. The person who got the empathic visit, they just, they didn't want to make the care provider feel that they were like being a big whiner. And you can think of a million different reasons why you might want to say you're a little bit better than that. Okay, I get that. Now, what really made this study extraordinary is that they studied a biomarker. And it was a biomarker taken from nasal secretions during the study. And it's something called Interleukin 8. It's a cytokine. And it correlates with how many inflammatory cells would be present to fight the viral infection. And here's the results of that. And this is in units. Not important which ones they are. This is the phone call. This is the standard visit. the enhanced visit. So not only did empathy result in clearing of symptoms more rapidly, but it actually moved a biomarker, by the evidence that was provided. Now the study is being expanded and explored. So, there is a notion here that this is more than just making people feel good. It actually has a biologic effect. So there's been a lot of speculation about this. And I talked to the pre-med students today about this. What happens to your empathy? I believe that there's very good data to show that you have your highest empathy the first day of medical school. Pretty damn good. Everybody's ready to go. And then, these are different models. And there's the green up here. This person never loses it at all. This person somehow, somewhere in here, falls off the cliff and they're in trouble. And then other permutations. What has been found in most studies is that by the time you get to the third year of medical school, when you're launched into the, quote, wards, which are not wards, but the hospital practice of medicine, you're vulnerable to lose your empathy. You're exposed to what we call the hidden curriculum. Hidden curriculum is, you're taught in the first 2 years how everything should be. You get out there and you see physicians who may not be happy, who may not be acting professionally. You may see interactions at work that are not really role modeled in a way that they should be. Yet, 1 out of 3 people, they stay right up here. Everybody else is kind of different. So this is the science that we're working on, trying to figure out, can we move this? Can we buffer this? Can we go from there? Why would you lose empathy? I already said the hidden curriculum, high volume of work. It's hard to be, empathic and emotive when you're getting crushed. So that can't do anything about that. Time pressure goes with that. Patient and environmental factors. I said this to the students today. It's so easy to be nice to nice patients. So easy. You just feel like loving kindness. But when somebody's spitting at you, it's hard to be empathic and it's hard to be nice unless you have something inside you that recognizes that this person is experiencing their darkest night and their life is messed up. And, this is not about you, it's about them. So these are important things. And then lastly, this notion, Abraham Verghese, I hope anybody's read any of his wonderful books, My Own Country, The Tennis Partner, Cutting for Stone. He's now at Stanford and a great medical humanist. He wrote an editorial a decade ago called The Eye Patient versus the Real Patient. So, I'll come back to that in a minute, but that's what I'm talking about there. So I've asked these questions. Burnout is a reason for lost empathy. So everybody kind of knows what burnout is. You get burned out in any profession. Policemen get burned out. EMS people get burned out. Doctors and nurses get burned out. It's really a lack of, it's a presence of emotional exhaustion, a sense of depersonalization, loss of joy in your work. It's kind of like, the Judge Hugo Black defining pornography. He said, I can't exactly tell you what it is, but I know it when I see it. And that's what burnout is. When you see a burned out healthcare worker, it speaks for itself. This is not a pretty sight. So what do we know about this burnout thing? It's highly prevalent. Get it in medical school, comes on in residency, comes on in medicine. If you're all pre-med, you're thinking like, why the hell do I want to go into this thing? Everybody looks like they're toast. We're starting to meet this head on and figure this out and gain insight into it. And trying to dissect it. Same causes of loss of empathy are the same reasons that we lose, same reasons that we get burned out. So how do we stop it? So there's a study, famous study, done by colleague Ron Epstein and a group from the University of Rochester. The University of Rochester Medical School is one of the leading schools in humanism and medicine in the country. Very innovative curriculum, not separating mind and body. And so they took a group of care providers and they put them through this rigorous 8-week course. Had mindfulness meditation, this kind of self-awareness exercises, something called Appreciative Inquiry. Who knows what Appreciative Inquiry is? Is it at all? It's a technique that came out of the business schools. It's about learning. It's trying to make your business better by learning from situations where you're doing good. You know, when you're functioning at your best, tell me, share this with me, so I can learn how to emulate. It's not learning from your mistakes or punishing people. In your job, when you're at your best, what do you like? So that's called Appreciative Inquiry. And all of these things were applied over an 8-week period, and the results were robust. And these people was associated with short-term and sustained improvements in well-being, attitudes toward patient care. Also improved empathy is one of the subscales in this. So we know that there are things that we can do. So that brings me to part 3. I might call this part 2, but it's actually part 3. I am dyslexic and I can't get these numbers right. So. I have a hypothesis that mindfulness as a technique, is something that's often talked about, may be an excellent treatment, if not cure, for loss of empathy and burnout. And I'd like to talk a little bit about this for a second. So here is a study that deserves a little bit of thought. So here's a thing that says, physicians self-assessed empathy. So you take the Jefferson empathy scale, you have high, low, or medium empathy. Then ask the patient, does your doctor have high, low, or medium empathy? Well, ideally they would all match up, right? But what has been found in several studies is that there is a very weak correlation with the patient's assessment of the doctor's in their head empathy levels. So what's that all about? Well, remember, our definition of empathy is not only being able to stand in another person's shoes and take their perspective, it's your ability to communicate this back. And that's where this really starts getting interesting. So if you can't communicate your empathy back to someone, you just sit there like Mr. Spock, it's not helpful. So there are some roadblocks. So there's a chasm between these goals, patients and doctors. There's some data I don't have reference on here, but doctors are pretty bad at interrupting patients. And they usually interrupt the patient within the first minute. Okay, so within the first minute. And then patients feel that they weren't really involved in their own decision making. All right, so this is fabulous. All right, so look at this for a minute. All right, so this is an 8-year-old girl who drew a picture of her visit to the doctor. So what do you see here? Happy girl, sitting on the table. Family, who's this? Grandma, mom, sister. Who's this? Doctor, what is he doing? Yeah, who's he looking at? Yeah, nobody. So this is part of this communication gap. Well, maybe in his head, he's hearing everything she's saying and feeling empathic, but this is not going to work. So everybody knows that this is a really bad thing, right? You don't want to do this. So we have a new way of thinking. That's, we call it texting while doctoring. That's improper use of the EMR. So now our students are being trained to use the EMR as a prop, not as something, and our rooms are being designed that I can look over the EMR and I can talk to people. I mean, this is all important stuff. It's just not just going to happen. So we have to work on these things. Fabulous book, number 3. It's called Attending by Ron Epstein. He's the guy that did the study of mindfulness and appreciative inquiry and showed that it decreases burnout, decreases empathy. Really talks about the notion that when you're a healer, when you're in medicine, one of the goals is to actually be there. I mean just physically. I mean existentially be there for the patient. You know, that they know that you're there with them in mind, body, and spirit. And that's here. So I tell my students and residents and fellows, you know, this is where we want to be, but every day we may come in differently. We bring a different person to work every day. You do that here, you do that at college, you do that as a student, you do that in life. You know, sometimes you come in, you're just bored to death, and you're just cranky. Or sometimes you're bored, but you're happy, but you just don't know what to do with yourself. Other times you're so, sympathetically discharged that you're in high gear, with or without anxiety. The idea is to come here in the middle path, in the optimum work zone. When you do that, all of these things about being there for the patient, being able to hear them clearly, hearing them deeply, and being able to communicate it back go much better. So that brings us to, how do we get there? How do we get into the optimum zone? I think that there are techniques that abound that involve the practice of mindfulness, and there are many, many forms of mindfulness. I'll come to in a minute. Meditation is merely one of them. Everybody has their own kind of techniques, but this may be something from mind-body techniques like yoga or Tai Chi. It may be meditation. It may be things such as hypnosis, Feldenkrais. There are a number of different techniques. So I'm not saying there's one thing, but it is putting you together in a minute-to-minute appreciation of what is happening now. You sitting there, actually feeling your seat on this chair, knowing that that is what you're experiencing, and losing the notion that, I'm worried about, I have a test coming up on Tuesday, I have to, I had this really bad social interaction. Being able to be present at the moment at that time. So this is a program that we developed at the Cleveland Clinic. It's designed for people in healthcare, but it's basically classical mindfulness meditation. Now, before you bristle, we're in the presence of both a surge in the interest in mindfulness, but we're also present in a backlash against mindfulness. A lot of people are just sick and tired of the wellness hype. Is it overblown? I've seen studies which show that if you take a yogi who's spent over 60,000 hours meditating and you put him in a functional MRI machine and show this great expansion of his hippocampus and contraction of his amygdala, and then you say, okay, take 3 breaths, and that'll get you there. No, it's not going to get you there. You're not going to get to nirvana by taking 3 breaths. So there's a lot of hype out there. Mindfulness has been used by everybody from Wall Street bankers to make more money. I don't think that the Buddha actually intended it for that. But there is a science here that is being investigated, and I'll just give you some snippets. These are some of the techniques that the NIH considers mind-body techniques, and this includes dance therapy, breathing exercises, Pilates, prayer, hypnotherapy, etc. Let me just show you that there are examples already in the literature, probably over 15 examples, that if you engage in rigorous mindfulness meditation practices, you can actually change the way that your genes function. Science majors, you might recognize this. This is a heat map. This is looking at individual patients. The red are genes that are being turned on. You're looking at mRNA over here. This is novice. This is people that don't meditate. So these are hot genes. These are cold genes. These are meditation masters. As you can see, these genes here, which are turned on in novices, are pretty much turned off over here. And these genes that were turned off over here are turned on here. This is after 8 weeks of training of a novice. Well, they now look more like the meditation masters. So you actually can do this. So we're asking questions, how low is the dose? Maybe we can get there at 5 or 6 minutes a day. We don't know that. So it's an interesting concept. The second question is that, okay, I can turn my genes on or off with meditation. What is it actually doing for me in terms of this healthcare thing? And I think that there's a growing bit of data that shows that if you engage in a mindfulness practice, and we don't understand the mechanism of it, it actually makes you more compassionate. And this has been talked about anecdotally by a lot of people, and a study was recently done by this group of DeSanto and colleagues at Northeastern University. So they took 39 people who did an 8-week course of meditation, who had never been involved in meditation before. And they randomly assigned half of them to the meditation, half of them as a wait list. So, okay, you wait 8 weeks, and then you can get the meditation. And then 8 weeks later, so half of them have meditated, half of them haven't, they call them into the office and say that we want you to take this test, this psychologic test. So that's the setup. So they enter a room as part of the test. They don't know this. And there are 4 chairs. 3 of them are filled. So they come in and they sit in the 4th chair. Then a person comes in on crutches. They're standing there. And the other 3 people who are already there, instructed, they're part of the study, they say, you don't get up. And the test is the person get up and offer their chair to the person on crutches or not. Okay, now the only thing different between these 2 matched groups who were randomly assigned to meditation or not was that one group had done it for 8 weeks, the other was waiting to do it 8 weeks. Classic mind-body stress, mindfulness-based stress reduction. So, you know, the answer is the answer. So, whether you're a statistician or not, the answer was this. 16% of the controls got up to give their chair away, and 50% of the people who were doing mindfulness meditation did. 50%. I have one of my old friends, smart guy. When you look at data like this, you don't have to be a statistician. This is very impressive and palpable difference. It was statistically significant. And it's particularly, they achieved something particularly rigorous because there's a thing called the bystander effect. If you take psychology, you know about this. So if you're walking down the street and there's somebody lying there and says, help me, you'll stop and help them, probably. If you're walking down a busy street and 20 people just pass this person who's doing that, you're far less likely to stop and help them. This is the bystander effect. So they overcame that to do this. So pretty cool stuff. And then we know that the actual functional MR and the neurophysiologic aspects of doing mindfulness-based stress reduction and other forms of meditation actually are very complex, and that when you meditate and focus your meditation on compassion, which there are types, loving kindness and things, you actually have a very complex neurophysiologic outcome. I don't want to go into that. So now let me tell you something that's really interesting from the student perspective. So this mindfulness stuff is so poorly understood. I think it's reflected by this. So this is, how many here either know of Headspace or use Headspace? Okay. Let me do a big shout out for this right now. So I use Headspace, even though I have my own program online. So I pay like $100 a year for it. If you're a student, you can go on and get Headspace for $9 a year. $9 a year. It's unbelievable. It's so user-friendly. And the first 10 days are free anyway if you just want to try it out, which I strongly suggest. If I'm doing anything here, actually there's two things. I want you to try Headspace, and then I want you to follow me on Twitter. So I really give my worldview on all of this stuff on Twitter. So I'm easy to find, Calabrese, D-O. Easy. So they picked Headspace. This is a medical school in Southern California, and they assigned these people to do Headspace or no Headspace, and they followed them over the course of the year. It was a well-controlled study. And this is looking at medical students, very high stress. This is perceived stress, way down in the meditating group, no change in the other group. General well-being, up. Now, if you look at these two curves, which are parallel to each other, this is the per protocol involvement. So per protocol in a scientific study means you've actually done the technique. You've actually, they measured adherence and they did the Headspace as many days that they were engaging. The intent to treat is that you take all the people in the study who are randomized to meditation, and even if they didn't do the meditation, after the first week they stopped, they quit, you're considered in that therapeutic group. So that's a very hard thing to overcome. And what has been found in multiple studies of meditation is that just starting it, just understanding it, just being able to listen to that voice in your head without wigging out has an enduring effect that lasts a long, long time. I wrote a recent editorial in the Journal of Patient Experience. I said, the title of it is Why Mindfulness, Meditation, and Healthcare is a No-Brainer. And the reason is that you got nothing to lose. There's no downside to trying this. And there are now many ways to do it. That's my editorial, so that long. So my last slide is this. So I've tried to make a case about empathy as being important in healthcare. I think that there's strong evidence that it leads to better care, better caring. I think that there are forces at work that compromise our empathy, that we're gaining insight into, and I think that there are pathways for dealing with it. And now, I only am mentioning one. We have some healthcare administrators here. I wonder where they are. And the role in actually trying to close this gap. There are things that your workers can do, but there are also things that institutions need to do to discriminate this. I'm not lecturing you. I'm just engaging you. I know you think the same way. So this is not a two-dimensional solution to a three-dimensional problem. And the last thing I hear is like, okay, I hear so many criticisms of this, of people going, okay, I'm stressed out, I'm overworked, I'm already doing stuff. And you're asking me to do something else? Like, how the hell am I going to do that? Is it going to change how many patients I have to see or how few minutes I have to see them? No, it doesn't change your life experiences. It changes your relationship to those experiences. We like to say that, your brain is like an ocean. And when you're agitated, it's like these waves just get bigger and bigger and rougher and rougher. Well, that's because life is tough, and that's happening all the time. Meditation doesn't make those waves go away, but it allows you to kind of like surf over them. That's exactly what it does. And we're trying to study this in every way, shape, or form, and engage people. Our Stress-Free Now for Healers has been used now by 2 major healthcare systems. It's been given to thousands of patients, thousands of healers, nurses, physicians, primary caregivers. And what we know is that when it's engaged with, on-the-job stress decreases dramatically. What we also know is that if employers springboard them and give them a little bit of time to orient to them, to the programs, the adherence goes up much higher. So that's how I say we do this. So now there are limitless resources. This is our program, Stress-Free Now. The app is free. The program online is $50 for life. If you are still skeptical, get Dan Harris's book, Meditation for the Fidgety Skeptics. It's a fabulous book. I love it. And then over here is just the big world of what's available for you online. So I'm going to stop and open this up for a little bit of show and tell and discussion. So thank you very much. Happy to take any interactions from the audience here. Yes?
To what extent is this gaining traction in medical schools, let alone out in the profession?
Yeah.
Are you getting pushback?
Well, okay, so I'm firmly of the belief that when you're doing something that is genuinely original, you will get pushback. And I also believe that if you don't get pushback, you're not pushing as hard as you can. So pushback to me is good. There are, I forget the number, but there are several score of medical schools that offer elective mindfulness programs. So now you're kind of, okay, well the choir is going to go do this, so that's our medical school. We have mandatory, and it's not, it's not like MBSR, but in the 3rd year we do a seminar on empathy, a seminar on mindfulness meditation, and then for every session that we get together with them every 3 weeks for the year, we introduce it with a new mindfulness technique and a new kind of medical background and motivation. So they get to experiment with it. We spend 15 minutes getting people going, and at the end of the year, I get these evaluations, and a lot of people say, this was very interesting to me. It was very valuable. Some people said, don't force me to meditate. Okay, I get you. I hear it. And we didn't force anybody to do anything. He said, if you don't want to meditate, just sit there and have flights of fantasy. I don't care what you do. Just close your eyes and chill out. So yeah, it's getting traction in there. But as I say, our Stress-Free Now for Healers has been literally used for many, many thousands of providers, and that's the program we're doing most of our studies with. Anybody have any personal? Yes?
There are so much books on meditation and literature. Which single book will recommend to a physician to read?
If you had to, you wanted to actually get into the practice of it and understand it, I really like Dan Harris. And his first book is called 10% Happier. Dan Harris, you've seen him on TV, he's a CBS morning news guy. He's got a podcast called 10% Happier. I listened to one on the drive up here. It's very good, and he's a high power, CBS executive. He came to this kicking and screaming, and now he's all in. And he talks about, how a high power person can get into this and still maintain their competitive edge, still be engaged. and kind of work themselves into it. So that'd be the first book that I would like. In medicine, both of those other books I gave you, Rachel and Epstein, those are very meaningful from a provider point of view. You would enjoy them. Anybody have any mindfulness stories to tell? Anything to share? Try this? Good. Yes? She outed herself. Oh, so great. We have small groups in our medical school, and I've been teaching. I have a small group co-preceptor who's a very prominent pediatric ID person, and she went through a very stressful point in her life in the past 6-7 years, and she actually took up mindfulness while we were teaching it. She took it up, she went to a silent retreat, and now she just got certified as a yoga instructor. And she's just like so chill. She said, totally transformed her life. I don't want to sound like a zealot. I'm not trying to sound like a zealot. You know, the worst thing happens. You try it and say, like, I don't like this. But and the practical tips. This is not a sell or telling you how to engage in mindfulness. But I'll tell you the things, the myths that dispel. If you're thinking like, maybe that guy, maybe I'll try a little bit of this. I'll download Headspace and try 10 days for free. It's not, and you think like, I can't do this. I can't make my mind go blank. I've tried that before. You don't make your mind go blank when you're meditating. You're being with your mind. So you don't make your mind go blank. Don't make your mind go blank. Don't make your mind go blank. Secondly is, I don't have enough time for this. I don't have enough time for this. I don't have enough time for this. We believe that, doing it a minute a day is a great start. Everybody's got a minute. And so it's an interesting approach. And, I've been teaching this now for a number of years. And I'm trying to figure out how to empower people just to try it. If you don't like it, don't do it. It's not like it's the end of the world. And everybody has their own thing. There are people, social psychologists like Adam Grant, he rails against this stuff. Because I have my own mindfulness in my life. I exercise or do this. Okay, it's great. And some people have what we call trait mindfulness. And actually you can measure that. There's a psychologic test. You can say, how mindful are you right now? Just, and then if you never did any of these techniques at all. So people that are hugely mindful, maybe they don't need to do this. Most of us aren't. And it's an interesting way. So this is where the research is going. Yes?
I have a question about physician burnout.
Yeah.
Does that present differently with
that's a great question. I'm not totally facile with that literature. I think that the core elements of depersonalization, loss of professional satisfaction, and loss of empathy are core features. I don't know if there's gender differences. That's a great question. I'm sure it's been looked at because everybody's looking right now. Everybody's trying to figure out how to work with this. People who love their work don't get burned out. And so it's a very delicate balance of trying to work through these things. Yes?
I think at least since men don't have networks to speak of, and in competitive situations of practice and training, you don't share, just like the suicide ideation goes up, you don't share that you're in trouble. You don't tell your colleagues you're not feeling well, that you're ill. If you're an older practitioner and you have some health problems, people will stop referring patients to you because you're overworked and not feeling well, and it just kills your business.
One of the great buffers for burnout and all the attendant features here, and this has been demonstrated quite clearly, is to have a trusted peer to share it. And the guy who's the dean of our medical school, who's just named dean, he and I have been working together for 15 years, and we usually walk into each other's office and put a nickel down on the desk and said, I need 10 minutes. I got to talk to you. Kind of like the Charlie Brown thing. And it just, you've got to process things. You just can't keep things to yourself. And that has been shown time and time again to be so helpful. We did a study about 5 or 6 years ago where we took senior physicians in the clinic at main campus, most of which were teaching medical school. And we brought them together one morning a month for 12 months. And the format was that there would be a topic that someone would discuss. Burnout or end of life or some formidable topic. And then it would be presented. And then everyone sat at a table, round tables, and we had like 20 people. And the task was to write the story in 10 minutes, 12 minutes at the most. So we call this guerrilla writing. It's not like edited this, like that. Tell your story about this. And then, for the rest of the morning, people at these tables would read these stories that they wrote. I want to tell you, it was like cathartic. You'd hear things from these guys that you've worked with for 20 years that you had no idea was going on in their heads. And at the end, we did serial studies of stress, burnout, empathy. Everything went up in the group. And there was another group who were waitlisted for this, who just got the readings on the problems, and they stayed the same. So, I mean, it's being creative and sharing. When you try to overcome all these travails of modern medicine and change, and which is so stressful, all by yourself, that's a very high-risk situation. Yes?
I have a question. Is empathy correlated with social justice and environmental ethics, like food support, equality, or equity?
Yeah, that's a good question. Social justice and empathy. I don't know any studies that have looked at that. You would kind of intuitively think that more empathic people would have stronger frameworks for social justice, but see, it's a great study right now. There you go. Another nice thing about empathy work, it doesn't cost a lot of money. You don't have to build a laboratory and a P4 containment wing. You can do very creative things. You just need to think aggressively.
Dr. Keller, I imagine most young folks looking at medicine as a career are thinking they're going into a particular area, immunology or radiology or public health or infectious disease. You've gone into multiple areas in medicine in your career. How is it that you gained such a far-ranging medical career and thought that you are?
I told you earlier, the Platte River over here, so a mile wide but an inch deep. I think that if I was to have the temerity to make some recommendations to people moving ahead, like we're talking to those nice high school students today, but really above that, and people who are getting closer to going to some type of professional medical school, dental school, nursing school, or our house officers, I tell people a handful of things. And one of them is to have no boundaries. I want to say, like, if I don't invent myself every 5 years, I'm failing. I mean, if there's something new, you should. If I did the same thing for decades, I would not be feeling as energetic as I feel now. I feel much younger now than I felt many, many years ago. So having no boundaries. Secondly is to really talk to your coworkers. And that means ask them a question. And that doesn't mean ask them one question, it means ask several questions. So you work in these big hospitals, and you come onto the hospital floor, and you're sitting down, and there's some nurse there, you've sat down, you've seen her a million times. How did you get this job? You know, how did you wind up in nursing? And get that little story, and then say, you know, ask one more question. And you find these miraculous things of humanity going on all around you. Third thing I tell people is that, and this is particularly important for healthcare workers, is that, and this sounds a little self-serving, but don't complain so much. You know, we're so good. Doctors are great bitching and moaning people, and they're so privileged. You know, we're the luckiest people in the world, and I know that things can be tough and that, but I mean, it doesn't really help that kind of contextualization of it. So when I tell younger people, particularly young trainees and stuff, when that's going on, just move. Just move away from that. The advice I gave to the kids who are going to college, I give that to people going into the profession. Pick your friends well. You know, I like to hang out with the humanists, and we feel great together. So those are just some closing thoughts for stuff. They've worked okay for me, and I think they work okay for a lot of people. So.